welcome Dr. Syed Akifuddin, is a postgraduate in oral and maxillofacial surgery. We welcome Dr. Sankalp Mittal, maxillofacial surgeon, currently assistant professor in GDC Jaipur. He's a member of Royal College of Physicians and Surgeons, Glasgow, since 2005, and fellow in International Association of OMFS and diplomats. Dr. Sankalp Mittal.
Thank you, sir. And good morning, everyone. And first of all, indeed, I would like to thank the organizing committee and Dr. Vivek Gaur, sir, to having me again here. It is always a pleasure to be a part of ICIC conference, like every time. And I would like to congratulate the organizing committee for this wonderful, successful conference. Thank you very much. And I'll be speaking on I have been asked to speak on the surgical anatomy of the inferior areolar nerve, which is of course a very important part of oral implantology, as you can see in this picture also, that we cannot dare to injure the inferior areolar nerve, not because we are afraid of any bleeding or any hematoma or any pain. We are afraid that what will happen to these lips if we injure the inferior areolar nerve, and how will we explain the patient, because lips are not only associated with the smile. The smile is the second best thing our lips can do. But the first thing is lips are associated, it is the best part of our body, which is associated with the love and affection, the expression of the love and affection. And we never want a dentist hand behind anything goes wrong with this organ of love and affection. But sometimes, unfortunately, it happens with our hands only, that the patient loses its sensation of the lip, or have some unwanted sensation over the lips. So why actually it happens? It actually happens because of nobody wants to do or injure the inferior areolar nerve, but actually it happens because we don't know where exactly the nerve is. Though most of the time it happens because we don't care. But sometimes it happens that we don't know where exactly the nerve is. So we know that inferior areolar nerve is a part of mandibular branch of trigeminal nerve. It goes into the mandibular foramen, and then this is the mandibular foramen, and after that the problem starts. Either you can injure the nerve before entering into the mandible. Yes, before entering into the mandible also you can injure the nerve, or after entering into the mandible also sometimes you injure the nerve, because you don't know where exactly the nerve is. Sometimes you are not able to visualize it. Sometimes you are able to visualize this partly. Sometimes you visualize 2 or 3 canals. You don't know exactly which is the canal is. So we'll discuss those factors. And then, so when the nerve enters into the canal, you should appreciate that the vein and the artery is on the lateral side. So when the nerve goes into the canal, usually in the ramus region, the nerve is on the medial side, and the vein and the artery is on the lateral side. And when it enters further into the ramus and into the body, the arteries and the vein lies superior to the canal. So that is the reason sometimes when you have a feeling of a dip into the canal, and when you have a bleeding also, still sometimes patient doesn't have any neural loss or sensation loss next day, because you have just injured the artery or the vein. And again, this is the reason behind when you have not exactly encroached into the canal, but still patient loses its sensation because of the pressure or because of the hematoma which is created because of the injury of the vessels itself. So it can happen in both the situations. And then actual problem starts when the nerve enters into the canal. Usually the size of the nerve is 2 millimeter to 3 millimeter. Sometimes it has been reported as 4.5 millimeter also, but it is exaggerated because it was measured on the OPG without taking consideration of enhancement. Usually it is 2 to 3 millimeters, so it shows you that when the canal is in the body of the mandible, and suppose you are lucky if it is on the one side of the body of the mandible, you have ample amount of bone remaining on which you can bypass the canal, because it is just 2 to 3 millimeter thick, and the remaining bone is there to bypass the canal. And it will be interesting